Welcome all, benvenuti to the 44th Helen Nahm Research Lecture. I am Elena Portacolone. Is it to... Welcome all, benvenuti. Okay, very good. And I am Elena Portacolone. I am a professor at the Institute for Health and Aging, and I am the 2024-2025 chairperson of the UCSF School of Nursing Research Committee. And a warm thank you to the members of the research committee, Abby Alcon, Yoshimi Fukuoka, Sujin Lee, Rene Meira, Maria Yefimova, and Aruno Suzuki for steering the Helen Nahm Selection Committee. On behalf of the committee, I thank you all for joining us today to extend our heartfelt congratulations to Dr. Susan Chapman. Yoo-hoo! For her achievements in nursing research, education, advocacy, and leaderships, and much, much more. The innumerable contributions of Dr. Chapman are an inspiration to all of us. And I can't wait to listen to her lecture. And so now I would like to introduce you to Carol Dawson-Rose, Dean and Stiles Professor of Nursing, Associate Vice Chancellor of Nursing Affairs, and the James and Marjorie Livingston Chair in Nursing Excellence.
Hi. Yeah, all you amazing people who came here to, listen to about your research, Susan. It's exciting. I'm just taking a deep breath, looking at all those friendly faces, which is good for me. I want to thank Dr. Portacolone and welcome everyone to our 44th Helen Nahm Research Lecture. I'm really happy to be celebrating with all of you and, to acknowledge the research career of Dr. Susan Chapman, who is our 44th Helen Nahm Lecture. Don't let that overwhelm you. I know. I want to tell you a little bit about Dr. Helen Nahm before we launch here. She received her diploma in nursing in 1924 and her doctorate in educational psychology in 1946. The combination of these two degrees formed the foundation of her career in nursing, leadership, and is an advocate for a model of nursing education that was considered at the time visionary and daring. She asserted that teaching was a form of inquiry and recognized that research and teaching were inseparable. She was also a pioneer in the efforts towards accrediting nursing programs through her work with the National League of Nursing. In 1958, she became the dean of the UCSF School of Nursing, where she served for 11 years. That seems like a really long time to me. Dr. Nahm created the first nursing doctoral program on the West Coast and established the Social and Behavioral Sciences Department, one of our shining stars in the school, and also Dr. Chapman's department. Dr. Nahm, this was the first of its kind in any school of nursing nationally. And Dr. Nahm brought in sociologists to teach our students how to conduct rigorous qualitative research. These sociologists contributed to a transformation, I don't think it's too small to say, in social science and in nursing doctoral education and research. I got to co-teach once with Adele Clark, well, twice actually, and she told me the whole history of the grounded theory event. It was amazing. It was so amazing, historical experience. These sociologists have really contributed to a transformation in social science research. According to Dean Nahm, the primary function of graduate programs is to prepare nurses for leadership positions in education and nursing service, and for research. Research is the portion of Dr. Nahm's legacy that we are celebrating today. In tribute to this far-sighted nursing leader, we are here to honor another extraordinary scholar whose work and teaching reflect the vision and spirit of Helen Nahm, and that's Dr. Susan Chapman. To tell you more about our esteemed honoree, I would like to welcome Dr. Stella Bialis, who is the eldest endowed chair and professor in the Department of Social and Behavioral Sciences in the School of Nursing.
Thank you, Carol and Elena. It is my great pleasure to introduce, on my behalf, but I also want to say on behalf of Joanne Spatz and Charlene Harrington, Susan Chapman as this year's Helen Nahm's research lecturer. I first met Susan when we were students in Berkeley, a couple of years ago. She was in the PhD and I was in the DRPH programs, but we took many of our classes together, and never in a million years we would have imagined being here together celebrating her achievements today. Together, we struggled to learning concepts that many have considered non-traditional nursing. Not Helen Nahm, but others have. And Susan had always offered me the assurance that that was indeed nursing. We did bond not only as the few nurses in the program, but the two nurses pursuing a deeper understanding of health policy and nurses' contributions to the policy process. Susan's nursing school roommate and lifelong friend reflected on how Susan's pursuit of her graduate education in itself had opened the door for other nurses to consider the possibilities, and how Susan serves as both an inspiration and a mentor to so many of us. Susan, then and now, always impressed by her commitment to advocate for the role of nurses as agencies of change in policy, no matter where you are or where you work. We'll hear more about her research shortly, but I want to say that the impact of her work has made so many people's lives better. Most people that may never heard the name Susan Chapman and may never hear the name Susan Chapman and don't know that some of the changes from which they have been benefiting from have been guided by policy changes informed by her research. An important contribution of Susan, in addition to her research, who has transformed healthcare in so many ways in healthcare policy, is that her commitment that she has made to education and mentoring and supports of dozens of learners and encouraging learners. In fact, a group of her former students sent the following message. We, your graduate students, want to extend our warmest congratulations to you on being honored as the recipient of the 2025 Helen Nahm Research Lecture Award. This image, I need you to come here now. This is a surprise.
Yes, it is.
Come here.
Okay. Oh.
Oh, sorry.
Thank you.
You don't have to hold it right now.
Just a place for.
Yes, this image may have been created, that's from the students that request that we read the message. This image may have been created decades ago, but its message is right on time. Become a nurse, your country needs you. This message captures the drive you instill in all of your students through the School of Nursing Health Policy program over the past several decades. You communicated to us by education and by example that as nurses, we have both the opportunity and the responsibility to use our knowledge and skills to make a meaningful impact on our communities. Your teaching, leadership, mentorship, and vision have made it possible for us to have a seat at the table to promote health locally, nationally, and globally. We are so proud to be a part of your academic family. From the bottom of our hearts, we send our gratitude and our love. And now, without further ado, I really want us to hear from Susan about her amazing achievements. Thank you, Susan.
Let's start with some water. Thank you, everyone. That was a surprise. It's great to see you all here. Recent colleagues, older colleagues. Can you hear me okay? Or okay, great. I want to acknowledge and thank Dean Dawson Rose for spending time with us here today. I know you have many things on your plate, so thank you for your time and kind introduction. Thank you to the research committee for this award. I'm really surprised to hear it. Thank you to my nominators, Charlene and Joanne, who couldn't be here today, is actually at a nursing workforce conference. So leadership of the School of Nursing, staff, faculty, colleagues, students, a number of students here, research colleagues, friends, Diane, hi, thank you for your words, my college roommate. And I have some family on Zoom, I think. So thank you for joining. I also want to acknowledge and thank the Ramaytush Ohlone people who are traditional custodians of this land. We pay our respects to the Ramaytush Ohlone elders, past, present, and future, who call this place, this is the land that UCSF sits upon, their home. We are proud to continue the tradition of coming together and growing as a community. We thank the Ramaytush Ohlone community for their stewardship and support, and we look forward to strengthening our ties as we continue our relationship with mutual respect and understanding. I had the opportunity this year to do a research project, actually my first one, with some tribal communities looking at some of the factors as they live in very rural areas and need, particularly during COVID, need help with just basic care and resources, and see what challenges they face and how you know, centuries of oppression have really left them with few resources that are needed, and really got a good picture of what we need to do as a country to address those issues. So I was really, and I thank Jackie Caslow for her participation in that program. Change agent is a little bit of a buzzword. I sort of wondered about using that, but I think it's, you know, it's being used too much in some ways, but I thought I'd use it anyway. So I'm going to talk to you about my health policy journey. I hope it makes sense. It feels like when I look back on my career that it was a little bit disconnected in all the different things I did and still doing, but I'm going to try to make it fit together and hope that it will. And if it doesn't, I'm sorry about that. I also want to recognize Dean Helen Nahm and her legacy. I'm very pleased to be from the Social and Behavioral Sciences Department. Several of my colleagues here today, thank you for coming. And IHA is Institute for Health and Aging, also part of that department. She really believed in nursing leadership from an early stage of her career, and professional nursing as an independent practice, sometimes that we still struggle with. I really wish I could have known her, and I'm really honored to give this talk in her name. I know we always start at the beginning of our career, so I'm going to go to 8th grade. I found this, you know, I've moved so many times, but somehow I still have this career notebook. This was 8th and 9th grade. It was a civics assignment that took 2 years to do. I was aware of nursing a little bit from friends and, you know, seeing people in hospitals, and my mother was a real proponent of me being a nurse and encouraged it. And as you may recall, some of you, this was one of the careers that women could do, and it was a choice. So I pursued that in my career notebook. A couple of things that I highlighted here that I wrote at the time. A growing field of specialized nursing and public health. So we were aware of the public health needs even back then. I liked this. Today's nurse is a combined doctor, psychologist, and part-time mechanic. I don't know where that came from, but I like that quote. The other, and then I saw, you know, a few years ago, they were considered duties only a doctor could do. And I find fault with that in the sense that nurses have always had independent duties. And so whoever wrote this, I think, was writing it from a physician perspective. Also to note, I use the Occupational Outlook Handbook. I probably didn't even really know what that was at that time, but I still use it as a data source. So this is from the Bureau of Labor Statistics that has data on workforce. So I was surprised to see that I actually knew what that was and used it as a reference. My first stop in nursing education was at the University of Iowa. And I thank Diane, my colleague, who's on Zoom, for letting the dean there know. And she sent me a nice congratulatory message and a mug to come. So I'm trying to wrap this up into a few key messages. One, I think the first one was, you'll never change nursing. I was in a clinical area and I must have said something. I try not to be too pushy, but anyway, I must have said something that set off my faculty member. So she dragged me into the room and she said, you will never change nursing. And I thought, well, that's a call to action, right? You tell me I can't do something, that means, okay, I'm on it. But how do you really do that? How do you make those changes? So that was a big piece that kind of set me off on. I really, and many of my nursing colleagues were also at the same point, like, we need to really sort of change this structure and be more leaders. The other thing, as I thought back about it, was learning about cultural competency, although I didn't know what those words were or what they meant. This is a picture of Kelowna, Iowa. Has anyone ever been to the Amish settlement there, or other Amish? Okay, good. So it's very much it's a closed community, but you know, it was close to Iowa City, so I had I had a patient there who was a 90+ something woman, and I was there to bathe her, take her vital signs, you know, see if she was doing okay. And we didn't have a lot of conversation, but she was very nice. One week, so what I did is they didn't use buttons or zippers or anything, so I had to pin her clothes back on, and it took some time. And so we had nice visits. And then we got a call to the school saying she had died, so I didn't need to come again. My professor said, oh, you have to go out there and do grief counseling with them. And I said, oh, I've only waved at the daughter she's working on the farm. I don't really know her. So she said, go ahead and go out there and do it. So I went out there, and the first thing she said was, why are you here? Didn't you get the phone call? And I said, yeah, I wanted to see how you're doing. You know, can I give you any support? And the look she gave me was like, what are you talking about? Where are you from? And it made me realize that I wasn't the right person for that. This was a culture I didn't understand. I wasn't part of this culture. So what was I trying to do? Again, I didn't have the words for it, but it was really, culture's different, care needs different, families are different, and we can't step in unless we know what we're doing with that. The other thing I learned there was about research. In undergrad, we had a semester of leadership and research. So we did a research project. We had some methods, and we had to do a research project. I found this piece of paper in an old textbook. I hope it's just a draft of what we did, but it's, I sort of highlighted the key areas. So I worked on a urology floor for the leadership part, and it was a pretty, you know, intense university level urology department. It was very important to measure intake and output urology, but patients were asked to measure their own intake. So they had a sheet where they wrote down everything they drank, not their IVs, but their oral intake. And we noticed as nurses that they were inaccurate in their measurements. So they weren't getting accurate intake measures. So we said, well, that'll be our experiment. They'll ask patients, we'll give them containers of liquids and ask them how much they're in it, and, you know, measure that. So somehow, and I'm missing big pieces of this in terms of what we actually did, but we managed to get 15 people, and this rough graph here shows the measures of one, I think it was water. And we found that only, you know, 23% of that group was correct. I have no idea what those confidence intervals were drawn from, but anyway. So the big thing, though, was we wrote this up. The reason patients were inaccurate in estimating amount was because 46 of them, and we did ask them this, had not received any explanation for how to do this. The nursing staff had not taught them how to do this. We were asked to present our research projects to the staff, so the nursing staff and a few of the residents and attendings came, so we presented it. What do you think the response was to our research?
I think they explained it.
What would was there a policy response? No. Thank you very much. Nothing changed. Thank you very much. Nice project. Go away, girls, you know, that kind of thing. So it also was, okay, a call to action. How do we make our voices heard when we do research? This was, you know, not very sophisticated research, but it was something. And we did find something that could have been an implementation of change, but it wasn't recognized. My next, oops. This was my first job post bachelor's degree. Does anyone recognize this place? Yes. 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 This was MG, Mass General Hospital, Ether Dome. This was where they invented ether as anesthesia. The reason I have this picture is because I worked in inpatient psych unit, which was right next to this. So I used to go in there for my breaks. I didn't realize that it was a historic site. Inpatient psychiatric nursing was so different than it is today. And I think in a good way, in many ways. And this was a short-term unit. Patients stayed between 2 weeks and 3 months. They got intensive therapy of every kind. Nurses were involved in every aspect of therapy with our own assignment of patients. So when I think about inpatient psych today and where we are in the behavioral health crisis, I think of where I came from, which was not affordable today, but how, you know, we're missing some of the key aspects of what it used to be. My next steps along the way, graduate school. Boston College, any other Boston College alums here? There are usually a few here. I did my master's in psych nursing, and that was full-time. It was very psychoanalytic. The theory was all psychoanalytic, Freudian psychoanalysis. It's every other theorist out there. I did my clinical work at the Cambridge Hospital. We did have to do a research project in that master's program, and we decided to do a survey of retired women. We got a list of retired women and sent out a survey about how is your retired life? You know, are you active? You know, we used some depression scales, et cetera, et cetera. And we did, you know, have some statistics, so we knew how to analyze the data. We didn't have any mentorship to write it up or get it published, but we did the research and learned, again, something else about research. And these women, some were very happy and very active, and some were very depressed in their retirement because they couldn't make the transition. I'm sure that's not true for anybody here. Right soon after that, I said, I really want something about integration. I want to, you know, we're not integrating physical health with behavioral health and more policy stuff. So I went to BU. I was running out of colleges with Boston in the name, but I did BU. It was part-time, so I was still working as a nurse, and it was an MPH in health policy, law, and management. So I was learning a whole different side of things with epidemiology and biostats, health systems policy, a lot about health policy and law, and also a little bit about marketing. So from there, I move to the West Coast and go to the health policy program at UCSF. This was started by Phil Lee. There's a picture of Phil there, who was chancellor. He was one of the chancellors and served until 1972. He established the health policy program and really made some key, you know, changes and decisions in his chancellor role. It was also a tough time. So he, I didn't know this, he renamed the institution, the University of California, San Francisco. We had a slightly different name before that, which I forgot what it is. But anyway, that was another thing that he did. So I want to recognize my colleagues from the health policy program. This was our office on 3rd Avenue. A house which got turned back over. I think there were, I don't know, 20, 25 of us there. Phil and a bunch of different, staff analysts. We really enjoyed our time there. And I was amazed at how, what I learned about health policy and the community there. This was the beginning of the AIDS crisis, and San Francisco responds. I remember numerous policy sessions, conversations about the bathhouses. Should we keep them open? Should we close them? What are the policy issues? Who's, pro and con? Impressed by many federal policy making connections. Phil knew everyone. Learned a lot about healthcare economics and costs and tobacco policy. Our colleague Barbara Koenig was there doing ethics with Al Johnson, and learned a lot about interdisciplinary health services research. So our time there in that house, which is now, not part of the university, was interesting. And I'll tell you a little bit about my role in a second. This was my first nursing position in health policy research, and I have to thank Steve Schroeder for hiring me as a policy nurse. I had been job searching for policy, and I kept getting offers for jobs in psych and mental health, but nothing in policy. So he took a risk with me, hired me for something I didn't know quite what to do, but I said I could do it. And so you take chances, right? You can learn this on the job. And so I was really happy for him and John Sosak to hire me for this study. Now, this was our final paper, but the study was related to the increasing healthcare costs as a percent of the GDP, the gross domestic product. And as you remember, this goes back to the Carter administration. The GDP was on a quick rise in terms of healthcare costs. The question isn't, are these good costs, bad costs, or whatever? It's an opportunity cost. When you spend more of your GDP on health, you're missing out on other opportunities to spend. So there was concern about this and how are we going to get healthcare costs under control? The Carter administration and some other folks thought maybe it's a voluntary thing. We just tell hospitals to reduce costs and we teach them how to do it and it will happen. So this study, I can't remember the funders. It was a foundation. It wasn't an NIH study. Was to test the idea that we could come up with voluntary cost containment if we taught residents sensible ordering, look at what they had done. Some things were probably missing, but, not over ordering. At the time, the culture, I would say, for house staff was order everything possible just in case you get asked for that result. So there was a lot of, I remember the clinical lab person saying 50% of our tests are stat. So how do we manage that? So we had this intervention with Steve started the Division of General Internal Medicine. So a lot of those colleagues were part of our study too, but teaching the house staff and also looking at their care. So it was a little bit of a critique. I did the audits of the records so that they could look at, and so there was a little bit, why did you get 4 of these on the same day or whatever? But we also gave them pizza, so we got them to come to lunches. So we had 2 intervention groups and a control group, but every group got pizza. One group got just education and one group got this intensive audit. My role, I walked up that hill twice a day to collect data on the inpatient units, the acuity data. The nursing staff at that time had acuity sheets for each patient, so it was a scoring thing. So I collected acuity data, and then I participated in the learning and the analysis and then writing up. So our finding was kind of a negative finding. Physician education alone was not enough to reduce costs. We didn't find any huge reductions in cost. So it's sometimes a little bit hard to publish a no finding study, but they were very persistent and we got that published as well as several other papers. So in terms of my lessons learned, I think at the health policy program, IHPS, was how to conduct and publish health services research, a very aggressive group. As soon as you were halfway done writing one paper, you were starting on the next one. And, where else are we going to go for money, et cetera, et cetera. So those of you from IHPS know it was a constant grant making, grant submission kind of process. I really enjoyed learning interdisciplinary research and connecting with people from other disciplines, which I hadn't had a real opportunity to do yet. In terms of our study, I think we maybe added some knowledge about hospital costs and reductions. That we weren't the only ones doing research on that, but I think it showed that we were going to have to do some pretty different kinds of federal policies to really address cost, which did happen. The era of DRGs and all sorts of other cost containment things. Where we are now, with that, I won't comment on, but that was the beginning of let's cut costs. The next step of my journey, which may or may not make sense. Well, this was actually still part of IHPS, the health policy program. We had a Pew Charitable Trust fellowship in health policy for pre-docs, postdocs, and management fellows. I'm sorry, you can't see. And this is our group. You'll see Phil, Carol Estes. Let's see who else is in here that might be here. Anyway, these are the scholars. My colleagues, my close colleagues now, Jane Zones, Faith Mitchell, who I will wave to, Sarah Samuels, and I'm in there somewhere. This was a 2-year thing, and I was a little bit of the odd one. Most were pre-docs and postdocs, so I was assigned to the hospital to do hospital projects with a policy focus. So I worked with Bill Kerr, some of you may remember, Jane Hirsch, many of you remember, Marilyn Flood and others, Helen Ripple, to do what I would call program development type of research. I think the hospital was more a little bit not familiar with doing kind of big pieces of research to decide on program stuff. It was more, everybody wants this, so we'll do it. So I was assigned to several things. Should we bring liver transplant to UCSF? This goes way back, of course. And what would the impact be on surgical services overall? Because it's a lot of OR time and maybe, push people out of the OR, et cetera. Should we expand the number of ICU units we need? I think we only had 2 at the time. And then you have to look at costs and impact and all sorts of things like that, as well as the stakeholders on each side of the issue. MRIs were new. This goes way back. MRIs were new. So the question was, will MRI replace CT? That never happened. But what is the impact of starting MRI and then upgrading the childbirth unit, which was really about this competitiveness of childbirth units to make them more home-like, more family, fancy hot tubs, bedspreads, et cetera, et cetera. And UC was trying to get on board with all of that, as some of our competitors had. So those are just a few examples of my projects, a very different kind of research, I would say. So then my next stop, and I don't remember quite what the transition was, except an invitation to, by the way, a lot of these jobs were not jobs I applied for. They were word of mouth and connections and referrals. So I think that's always important to think about, is, keeping up those contacts and you get invited to stuff. I worked at Mount Zion before it was part of UCSF. It was a community hospital in the Western Addition, a struggling community hospital, and my job was to do planning. I did that for a few years, actually up until the time that Mount Zion, they called it a merger. It was really more a takeover, frankly, but it was Mount Zion joining up with UCSF. Then I went to Cigna, which is an insurance company, which, you don't ever go to a party and say you work for a health insurance company. But this was an opportunity, again, another friend called me. This was an opportunity to bring nurses into that structure. These were mostly life insurance companies trying to be healthcare companies. So it was, how do we bring nurses into the picture for utilization management, quality assurance, care coordination, case management, et cetera. And that was my staff, the nurses who we were trying to do that with. It was, frankly, a struggle. It was a struggle with the company. After that, this is after I started graduate school. Then I moved to Kaiser, and I'm going to go to the next graduate school in a minute. But these are my colleagues, actually, from Mount Zion, some of whom you might recognize. In the managed care world, things that were happening were performance improvement. Employers would say, we want claims, we want, phones answered, we want, this kind of service, et cetera. So we want guarantees of performance, and you have to put some money on the line. So if you don't perform these measures, you're going to give us some money back. So at Kaiser, I was measuring all these things. NCQA was the JACO equivalent for health plans. So you had to sort of show your quality metrics to be an NCQA approved health plan. Whether consumers knew what that meant, probably not, but it was a way into the market. Outcomes, HEDIS measures, these were kind of preventive measures that were measuring whether people had, breast cancer screening, prostate screening, et cetera. I think the lessons I learned there, and this is one that still troubles me, is we lost the concept of HMOs in this transition of healthcare. HMOs like Kaiser and many other around the country really were about health management, health maintenance, improvement, and very community oriented. And we have taken that name into managed care, and we've taken managed care into this new realm in a for-profit world. I won't go on and on about that, but I think that was one of the things I learned, is how that kind of transition happened, all about costs, basically. A lot of changing in how medical services were delivered with competition, medical group formations, networks, et cetera. But I think the thing I valued a lot was nurses as case managers and care coordination, and really helping people who were high cost, complex people to try to bring the team together, because that didn't happen then and it often doesn't happen now. So quickly onto Berkeley for my PhD. I would have gone to the health policy program here if it had been around then. But PhD at Berkeley, as Stella mentioned, we were classmates. I really wanted to learn more about research. In this previous job, I was doing a lot of research and doing a lot of process improvement, Deming model, et cetera, measuring. And I thought I need to know more statistics. I need to do more research. So I went to Berkeley. And the health service and policy analysis, not a lot of nurses, a few, Stella and I, and maybe a couple more. It was very much health economics, epibiostats, political theory, institutional theory. And I did my dissertation on young women with breast cancer and return to work with Professor Joan Bloom, who had an ongoing study about that. Jumping ahead back to UCSF, the Health Force Center at UCSF, which was formerly the Center for Health Professions that was funded by Ed O'Neill. Sunita Mutha is now our director. From this point on, I think I would say my research was focused mostly on workforce and workforce issues. And a lot of funding from foundations, associations, government contracts, state contracts, and a lot of collaborations outside of UCSF. So this is a recent picture we took last week at a retreat. A lot of my work initially was on what we call the allied health workforce, which we couldn't define then, we can't define now. Who are they? It's often who they're not, but often, non-licensed. We don't like to use the term entry level because they're really advanced in their careers and knowledge. So entry level is not a great term either. Paraprofessionals is not a good term, so we don't have good terms. But anyway, in general, why do we care about workforce? Well, these are some of the things. Supply, demand, occupational growth, projections, how many nurses do we need? How many doctors do we need? Where do we need them, et cetera? We're pretty terrible at distribution in this country, but that as well. Education, credentialing, what kind of credentialing, what kind of education? How does that change? We're, in a process now of changing our education. Scope of practice is a big issue, which I'll come back to, and also diversity. Worked a lot with community partners, a lot in K through 12 education, primarily in the San Francisco school districts. The question there is, how soon do you introduce kids to health professions? You want to be a doctor, you want to be a nurse, you want to be a whatever. Some people think you go to the elementary schools and do it. We did this mostly in high schools and with high school health programs and tech programs. It's a challenge because you don't want to peg people in a certain direction, but you also want to give them opportunity. So the K through 12 education kind of struggled with how to do these programs. The most success was from when you had a champion in the high school who kind of promoted and ran these programs. A lot of Department of Labor workforce development organizations, regional collaborations, professional associations. Just to mention a little bit, some of the emerging roles I worked on were medical assistants, very much in the medical practice, but did the, take you to your room, take your blood pressure, leave. With the complexity of medical practice now, who's going to make the referral, who's going to follow up, on your diabetes care, who's going to do, et cetera, et cetera. And with the stress of on primary care physicians and clinicians, medical assistants could really provide more services than they were doing and they were able to do. Peer support specialists are in behavioral health. They are support workers with lived experience from mental health or substance use. Some of you have worked very much with, looking at Shannon, very much with peer support specialists. Under-recognized, sometimes rejected by the team, a lot of stigma, but that lived experience is something that's really valued by clients in the community. And then community health workers who've been around since the 60s, but were mostly in community support functions and now are getting more of a role in healthcare teams. So education, role clarification, integration. These are just a few reports I'm doing. And just to say, I've done for these foundations, I've done a lot of reports and a lot of publications. I have almost equal number of each. These are different. They don't necessarily count on your CV, but you can turn them into publications. I'll talk about that a little later. But some of the professions, cancer registrars, who are they? What do they do? What do they need? EMS workers, a division about, are you a EMT or a paramedic? What's the difference? What's the future? Then one for a foundation on diversity, and then one in California on nurses' aides. So what I learned in this experience was different types of research funding and deliverables, relationships with a lot of different community members and stakeholders. I'd say the national impact was increased awareness of the allied health workforce. It's about 60% of the workforce. As I said, we can't really define it very well. IOM actually had a conference that I led to try to define it, and we never really came up with a good definition. But a lot of workers who might be engaged differently and might be able to do more than they are currently doing, and certainly part of the team. I want to call out our health policy program and teaching health policy, particularly Charlene and Ruth for starting this wonderful program with a grant from 2000 on from HRSA, which brought us a lot of students and support. So I want to thank Brandy and Charlene and Ruth for bringing this program and inviting me to teach in this program. We have had over 200 graduates, masters and PhD. That might be a little bit of a lower number. We recently merged with Advanced Public Health in 2022. Carol and I talked about that for years and finally made it happen. The careers of our students are amazing. Some are in the room. I see Leslie, Shannon, Nancy, CDC, World Health, state agencies. I meant to fix this. California Department of Public Health, industry, UCSF Health Leadership. A lot of our students in policy went back to the bedside, but took different roles. So it's not, you don't have to step away from the bedside or the hospital completely, but you might take a leadership role or a committee role or some sort of advocacy role. Hospice, academia, a number of people in academia. So really it was kind of make your own career. As we used to tell students, you're not going to find a job ad, health policy nurse. You're going to make your own way. It's a challenge, but we have a lot of success. Shannon, Nancy, Megan, I don't know if she made it. Some people on the phone, Leslie, Gina, who just retired. So we're really proud of our program and our graduates. I'm going to focus on a couple of areas in my remaining time in depth, and one is long-term care. I was part of this committee, an IOM committee on the long-term care workforce, and the question was really, what do we need to do to retool our workforce for an aging population? It really got a lot of press and a lot of acknowledgement, and even had a 10-year anniversary for the book in terms of what have we accomplished. One of the examples I'm going to talk about here is Bob and Mel. Neither could make it today. We send our best wishes to them. This was a big project that was funded by the Center for Medicare and Medicaid Innovation in one of their first rounds of grants. And the question is, what difference does training make on patient client outcomes? And so we worked with partnered with a union training organization in Southern California. This was looking at home care workers or personal care workers who cared for home care clients in the in-home support services program, which is a Medicaid-funded long-term care program. We did pre and post-training surveys. We trained a ton of people, and we got claims data from Medi-Cal managed care providers, which was one of our biggest challenge, because you don't actually get the claim, you get an encounter. So we had to do a lot of data futzing, I would say. It did take us 10 years to publish this study, which was an interesting piece in itself. But I think we contributed a little bit to an open question about we train all these folks, do they stay on the job? And then what difference does it make to the client care? We did see some evidence of reduced, emergency room utilization, and that workers felt more prepared to do their job. I'm just going to stop for a little water. You'll recognize these people. This is our long-term HRSA Health Workforce Research Center on Long-Term Care, funded by HRSA. We are one of 9 centers. We're the only center on the long-term care workforce. We were funded in 2013, and we're currently in our 3rd renewal, kind of in the middle of it. It's a cooperative agreement model, which means that HRSA has some say in the projects that we do. We do about 4 or 5 short-term projects each year, and we suggest them, and we also, prioritize them. Nancy's done some, but we don't go off on our own. They have some challenges and some ideas about what they want us to do. It's very broad. So we've done over 60 projects, 28 journal articles, 170 conference presentations. We have a very large team of multidisciplinary investigators from across the campus and actually across the country. And I'm sorry, I think Laura's at ICN and Joanne's at a nursing conference. So I'm sorry they couldn't be there. This is a study I want to jump into for a couple of reasons, and I don't expect you to be able to read very much of that, but this was a study of personal care aides and how do you use data to match people who need care with availability of caregivers. So on the blue and green screen is using the American Community Survey, which is the survey that took over from the long version of the census. People identify as having a self-care need. So we could identify people and where they lived and that they had a need for self-care. The darker colors are higher needs for self-care percent-wise. This other graph on the other side is where are the caregivers. And we were able to track personal caregivers in terms of where they worked. So we knew they were actively working, at least in times of the survey. And the redder colors are fewer people. So as you can see, we don't have people in the places we need them. I hate to call out the South, but we don't have, we have high needs and not necessarily a lot of workers. One could use something like this for a number of professions and use data to sort of see, we always wonder, do we have people in the right place? And some other people do this in different ways. Does it lead to a policy intervention? Not necessarily, but it leads to awareness. This was published in Health Affairs, a special issue, which I wrote an abstract for after we had done this survey and already done story maps. I don't know if you've used story maps or photo maps as a methodology, but it's a different kind of research where the photo map thing is you give people a camera and ask them to take pictures of their work and then you interview them. So we had published both of these things, and then I submitted the abstract in Health Affairs, which is very picky, said, take all that down. How many people looked at the site? You can't have that out there. We managed to get it published, and it was it was in this special issue. So key lessons learned in aging and long-term care, I think for me, a very practical one is how to publish both REIS and peer-reviewed papers. They do have to be different, but usually a brief isn't very detailed in terms of methods or some of the findings, so you can create a paper out of that. Luckily, aging and caregiving seem to be pretty bipartisan issues still, so we are hoping to continue all that work. Where you live matters. Which state you live in matters for your benefits, particularly in Medicaid. Long-term care services and supports is Medicaid, and home and community-based care is Medicaid. So we need to look to the future and see what that's going to look like in terms of support at home. But this is definitely varies state by state. There are workforce challenges in all long-term care settings, including all workforce in all settings, nursing homes, home care, assisted living, etc. Some of the issues regarding CNAs, HHAs, and personal care aides, pay, respect, demographics, turnover, and now I think I would add immigration to that list. More impact on our workforce. I think we've got a reputation as experts in the field. We did a lot of work during COVID with, how do we ramp up this workforce? What kinds of, job characteristics do we need, et cetera, in some of these emergency COVID shelters, who can do what? So we got called on a lot for that. This led to a lot of other funding and grants, including some NIH funding from National Institute of Aging. I think raising awareness of the challenges of the long-term care need, which we hear about all the time, but also the future workforce needed and how we're going to address that. And ongoing consultation with state and national policymakers. And I want to call out Charlene and Liz for their long and endless work on staffing in nursing homes and the progress you've made. Okay, so now I'm going to talk about nurse practitioners and scope of practice, which is another big area. I hope I have enough time for this. Have you all seen the nurse practitioner map, scope of practice map? This is the current one. So what this is about is scope of practice is a state regulation. It's not national. So each state develops its own scope of practice, meaning what nurse practitioners can do, do they have to have supervision? Do they have to have other documentation, et cetera? So green is the states that are full practice, yellow is the states with reduced practice, and red is restricted practice. And not to go into the details of what these mean because they're in the regulatory language. California has made some progress. We may be green eventually or yellow, but we're not, according to A&P, we don't have enough yet to change the color on the map. So we're very interested in this from a workforce perspective. Starting back, I started on this way back in 2010 when I was looking at payment regulations, and this was about the differential Medicaid payments for nurse practitioners and physicians, in that nurse practitioners were paid less by Medicaid. We also looked at, within the state of California, utilization as well as the economic contribution. Sometimes the question is, well, do they really add to the bottom line? Are they worth the cost, et cetera? So we did some economic evaluation to show they actually added to the bottom line. And these were in community practices. Then we looked at, this is with National Council of State Boards of Nursing. I've had 2 grants from them, looking at the impact of regulations. And I'll talk more about that study in a minute. The opioid use, I'll talk more about in a minute. And then I wanted to call out Sheer Winter, who may be on Zoom, this is at UCSF. She was one of our Robert Wood Johnson doctoral scholars who looked at measurement of non-billable service value activities by nurse practitioners, physician assistants, and clinical nurse specialists in ambulatory specialty care. She did this in the pediatrics units at UCSF and found nurses doing a lot of case management, billable, non-billable activities. So the value is not recognized. So this was one of the studies, the impact of state scope of practice regulation. And that was the question and the aim. We did interviews of psych mental health NPs. I'm going to say psych NPs for shorthand, in 5 states with differing scopes of practice: Oregon, Colorado, Illinois, Massachusetts, and North Carolina. We did 94 interviews with a number of people and then thematic analysis. Scope of regulations impact practice settings, cost of practice, cost of supervision, administrative burdens, collaborative practice patterns, as well as reimbursement. This isn't a quote necessarily, but we noted appreciation of collaborative practice and sharing expertise. However, the regulations also often hampered that process. During the opioid crisis, we did a study on APRNs, and this is all NPs, a perspective on prescribing medications for opioid use disorders. This is buprenorphine and some of those types of drugs. Again, the aim was to look at the barriers and the contributions. We did interviews again. We did 4 different states. We were on the road a lot. New Mexico, West Virginia, Ohio, and Michigan, states with different levels of opioid issues, as well as different scope of practice. We did 76 interviews with a number of people, including the regulatory boards, and again, thematic analysis. We found, and there are a number of papers in this area, that APRNs increased access to MOUD, particularly in rural areas, and provided holistic treatment, but regulatory barriers remain. This was a process where you had to have a waiver to do the MAT prescribing. The waiver actually went away, but there are still regulations in terms of training, and states can also impose regulations through scope of practice that are not from the federal regulations. So this quote is, I think of them, NPs, as being a little bit more holistic. It's good when you're in SUD treatment, it's important to see the whole person. So just to wrap up briefly, difficulty in changing nurse practitioner scopes of practice in the policy. It's not just because there are regulatory restrictions, it's because of that impact. The opposition to this is well funded, despite the lack of evidence. I call this evidence-free policy. Doesn't make a difference what the evidence is. Change is coming slowly. COVID brought some change in loosening up these restrictions. I'd like to think there's a whole body of literature out there. I mean, we're just a small piece of this, but I think that we contributed to studies about NPs, being safe, effective, cost-effective, big contributions to our behavioral health workforce. Collaborative practice, and this is a concept that it took me a while to come to, but the NPs didn't say they didn't want to work with physicians, or they didn't want to have the kind of collaboration and supervision, in the sense that it's sharing and talking about cases. So they valued that, but that's not what supervision is in the state laws. It doesn't work that way. And so that was some of the problems. Just to mention briefly, some of my global health experiences with Sally and the Gaia group, and we did some USAID training. I was part of the Afyabora Consortium, which was UCSF, University of Washington, some other universities, and we were training leaders in several African countries to be leaders and to sort of take over the leadership thing. So it was the, not give them the leadership, but teach them how to be their own leaders. I spent some time at UTS in Sydney, Australia, which was a lot of fun, wrote a couple of papers. And then I've been involved more recently through Charlene's connections, the Western University of Applied Sciences and a Center for Care Research, and their long-term model, which couldn't be more different than ours, being a social care model in a country that has no debt, but is being really careful about resources. Okay, National Clinician Scholars Program, postdoctoral program. 6 national sites were one of them. These are the other sites. Margot Kuchel started bringing us to UCSF in actually 2018. got me involved. This was the former Robert Wood Johnson Clinician Scholars Program that was just physicians. But to join this group, which was self-funded, they wanted both nursing and medicine together. So we did a whole lot of work, we being a big group of people. And UCSF became a program site in 2019. Here's our first scholar. Where is he? Anyway, you all recognize Jose, our first scholar. This is our leadership team. Linda Park took my place as director, and then Kristen, Mike Steinman from the VA. Hillary is now took the program director for medicine job, Jose, and then Audrey. Some of our grads, Rachel Otis, who went to Wisconsin-Madison, Ty, who's just graduating, is going to University of Michigan. Harry is coming to us at UCSF, and we have current scholars. Oh, then we have Edna, who went to UC Davis, Katie, who is an entrepreneur in the behavioral health field, and our current scholars is Brianna and Jean. And then we have 2 incoming scholars who are PhD graduates. So we're really proud of accomplishments in that program. Okay, so key lessons learned. I'll wrap this up now. Nurses need to be heard. This sounds a little trite, but it's more important now than ever. I mean, we've gone through periods where we have a hard time being heard. We're not always at the table, as they say. So it's more important than ever that we be heard, but it doesn't happen naturally or organically. We really have to know what we're doing and saying and how to insert ourselves and communicate. So for those people who say, what do I need to know about policy? And I have heard that in some classes. I just say, does policy impact any part of your practice? Well, yeah, a little bit. So I think, you know, it impacts all of us in whatever we do. I encourage policy research because of the richness and the interdisciplinary nature of it. I know a lot of our research is interdisciplinary, but I learned so much from listening to other people who have more knowledge and just the different ranges of things in policy. I think policy training is important for everybody, for all nurses, however that looks. We need to know what it is, how it impacts us, and how to be engaged. One of the ways to start is start with your passion. You know, when I teach this, what are you passionate about? What issue do you care more about? When I taught that in the DNPs, every one of them had a different policy issue, and the range was huge, but they cared about something, and they actually wrote about it quite well in terms of what needed to be done. Policy communications are important and another way to be heard. So publishing those op-eds and those letters to the editor and policy briefs for your organizations, I think, are another way to be heard. And you can put them on your CV. So I want to thank everyone for listening. Colleagues, teaching, research, School of Nursing, department staff, students, all mentors. Diane, thank you very much. We'll see each other sometime in Iowa. Friends and family, if you're still there. Anyone who helped me with this presentation, I got a lot of photos. I couldn't use them all, I'm sorry, but I have a whole photo library now that's interesting. And Brandy, thank you for helping me with the presentation. So thank you very much.
Oh,
Do you
thank
want-
you. That's good. Thanks, Susan. That was really great. And I've been excited. It does fall together. And from where I sat, it falls together. And I thought about you a lot over the past, I don't know, since January. Anyway, just the policy piece. We used to co-teach together. That was phenomenal. And I learned a lot about policy from you, my friend, my colleague. We have our gratitude, and I think, you know, it's an honor for this award, and you are an exceptional scholar, and it's amazing to hear you talk about your research. I have a couple of small gifts for you. First is on behalf of the School of Nursing in recognition of Dr. Nahm, and also about your meaningful achievement. We want you to accept this small token so you get to come back, which is the 44th Helen Nahm Research Lecture pin to you. And
Thank
it
you.
actually has your name on it.
Medallion.
Medallion,
Thank you.
excuse me, medallion. It's very exciting. Yeah. We have to do more pictures. Susan.
I think you have.
Oh, thanks.
Thank you.
Yes, and then there's one more. Sorry, yeah, I don't know about that. Yeah, you have one more gift. And this is from Diane
Oh,
Wiesenfeld.
hey, Diane.
And this is and I don't know if you want to wear it.
Oh, lovely.
Who sent this to you? Which is
From Iowa.
yes, well, I don't know if it came from
No.
Iowa. But as you mentioned her earlier, and she said she couldn't share pictures from your wild and crazy college years.
Yeah, we skipped a lot.
Yeah, yeah. But she wanted to send this to you in honor
Thank you.
of you today.
Thank
Beautiful
you.
flowers, yeah. And then I also want to thank everyone for joining us today to celebrate Susan as well as Helen Nahm.
Yes.
It's kind of an incredible legacy, and ask everybody to join us in the atrium out here where there's food, I understand. Drinks, I don't know what kind.
It was a wonderful opportunity and also scary at the same time. I mean, I do a lot of talks, but like this is with you folks, and you know, you are the highest standard here. So can I make this make sense? Am I up to what all of you have done? And really an honor to be given this opportunity, and also for me, an opportunity to try to put it all together. I spent a lot of time trying to put it all together. So hopefully that will help me in my reflections sometime. Thank you.
Yeah, I know. Well, I'm close to you.